Are we on? Hi everybody, we're on. Let's talk about the natural history lecture. This was, just for your notes, this was, never mind, I don't have the date on it. Apologize. Anyways, we're going to talk about the way HIV infects an individual, the mechanisms it has to go through initially, the defenses it has to breach, and we'll talk about how that looks in regards to testing and understanding treatment. So let's begin by briefly looking over these learning objectives on your own. Keep them in mind as we roll through. All right. And cool. We'll move into the a good illustration of how HIV infects. So we talked about HIV being present in fluids, right? It has to find a door, which is any basic mucosal membrane. We'll talk more about fluids and doors later, but it's a good thing for you to review, know all your fluids and all your doors when we talk about HIV transmission. We have virus hanging out outside in a fluid on a door, which is basically, like I said, a mucous membrane. But the thing about our mucosal membranes they're really good defenders. If we're going to go with like a Super Bowl theme, we'll say this is your offensive line. They're going to really keep everybody out that's trying to get in and protect everything behind it. So these guys are going to be like right up shoulder to shoulder, and they're going to try to keep the HIV out, and they do a good job of it. So HIV really needs to get through via a cell, right? So we call it, maybe in this case it's a Langerhans cell, but it's a dendritic cell, like a macrophage that we talked about already before in our talks about immunology. What these cells do is they kind of take some of this, they'll gobble it up and present it, but we also talked about HIV being able to infect these cells. So HIV needs to infect one of these cells and then create copies of itself. When it does, it gives it a bridge, right, to get across this epithelium, which is a really good defense system against normal virus that are just hanging out. But when HIV is able to invade, cross the epithelium, then it's allowed to get inside. This is where it can then invade and infect T cells and other macrophage, right? So the idea is this is effective for HIV because when it does invade these cells are going to send out a screen. We talked about how cytokines kind of work as a way to alert immune cells. So immune cells will rush to the site of infection, and HIV says, hey, this is great because these are the exact cells that I want to infect. So it's going to look for CD4 cells. Initially in infection, we already talked about this a bit, HIV is going to target cells that are CCR5 positive. These CD4, CCR5 positive cells are, as we said, T cells and macrophage. So these are important because this is the way that the HIV gets into cells across the epithelium. Another picture we already saw in our last presentation or our last review, we talked about how these GP41 proteins bind to host CD4 using CCR5 as the initial co-receptor. There has been one cure, or one individual who was HIV positive who is no longer HIV positive. This cure occurred in an individual called the Berlin patient, and it really focused on the idea that without CCR5, HIV isn't able to infect new cells. So without CCR5, HIV can't get close enough to then fuse with the cell membrane. We know from previous conversation that co-receptors are important in being able to draw this virus attached to CD4 close enough that fusion occurs with GP41. So a deletion mutation or a change mutation in CCR5 knocks out CCR5, so you don't have CCR5 on the surface of the cell, of the host cell, therefore HIV cannot infect the cell. So there was, in 1% of Caucasians, there is this mutation where homozygously CCR5 del 32 occurs. In this population, the small subset of Caucasians, a high degree of resistance to HIV infection is there. With heterozygous, meaning maybe one of the genes for the del 32 mutation is evident, like this says, progress to AIDS occurs more slowly, so viruses have a harder time kind of binding and then fusing with cells. So those are the ones we'll talk about here. Don't worry too much about all this stuff at the bottom. Okay, but just remember CCR5 being really important at the initial stages of infection because it's the first co-receptor HIV uses. Okay, awesome. So this is awesome that we have this science backed up because it really lets us look at some things This is one of Dr. Jacobs' wishes for you guys. But this Berlin patient is the one that we talked about. So this was an individual who was HIV positive, who had to get a bone marrow transplant due to cancer. So basically what you do when you're getting a bone marrow transplant is destroy all of your bone marrow, which destroys all of the cells that stem up immune cells. So you kill all the individual's immune cells and then replace them. It just turned out that the CCR5 negative individual that donated the cells gave the individual that was HIV positive who had leukemia new immune cells that were CCR5 negative. So eventually HIV was unable to replicate and invade new cells, right? Because we didn't have CCR5, so that eventually the patient was not detectable or HIV negative without ARV treatment in cells. Another picture of what we just saw, but it's important to know that because this time has to elapse where the virus infects and crosses that epithelia, infection and the ability for HIV to take up in an individual doesn't occur right away, right? It needs a little bit of time to cross these barriers. That's why post-exposure prophylaxis using HAART therapy is effective. It's more than 90% effective. And it's recommended if, like we said here, if you had an occupational hazard, if an individual was raped. We're going to spend a little bit of time with the next chart to understand some of this too, about the progression after infection.
Post-prophylactic treatment, 72 hours, 90% efficacy, 36 hours is golden, 24 hours is even better, but yeah, 72 hours is still okay. So,
yeah.
There's a question on Facebook about that one, so I don't know.
Yeah, there's a side note. Some of the guest lecturers talked about early intervention and the use of ARVs once you're already positive, once HIV past 72 hours has been able to replicate in your body, and post-exposure prophylaxis wouldn't be effective in totally clearing the infection. The idea that I think the guest lecturers talked about was outside of this, and they were saying as soon as an individual is positive, then we start treatment because it's earlier in disease course. Please differentiate that is not, they're not saying use post-exposure prophylaxis. Mm-hmm. They're just talking about the application of HIV, antiretroviral drugs and HAART therapy sooner in the disease course. We'll talk about that now, actually. So this is a chart. This is the most important chart you're going to want to know for this class. It talks about a lot of great things. We're going to talk about the course of infection. So we initially get infected with HIV, and this is your viral load. So as your viral load goes up, you're going to start creating, this is your viral load. These are your CD4 count. This is your CD4 positive cells. As the viral load increases, it's going to infect and kill CD4 positive cells, T helper cells. So your T helper population is going to decrease. You're also going to start to create antibodies a little bit later on, 2 to 4 weeks into infection, right? Because you have an immune response. And we talked about how B cells are going to make antibodies that can neutralize HIV as well. It's important to know that at the beginning of infection, the only symptoms ever associated with infection of HIV before progression to AIDS is basically flu-like symptoms. And that only occurs right after initial infection when your body's creating an inflammatory response. And so at this point, you're creating this response to fight it off, and the only real symptoms that you're going to have, or the real sickness that you're going to feel, it could be flu-like symptoms associated. And that doesn't even happen 100% of the time. Mm-hmm. Absolutely. So sometimes an individual would never know they were infected because nothing would ever feel wrong until later in disease progression. We'll talk about how that looks. So we talked about increased antibodies. As the antibodies increase, like we said, they're able to neutralize this virus, and it brings the viral load down without ARV help, right, to a set point. So we talked about the viral load set point being the point at which the body naturally can reduce the viral load in the body and reduce the amount that HIV is able to replicate on its own. At this point, you're going to see a bit of a recovery in the CD4 positive cells. And let's keep going. At this point, we're going to hit the latent period. So when these settle out, your antibody level settles out, your viral load sets, you're going to see a latent stage of infection where there's going to be no symptoms associated. So we're going to call this the clinical latent period, the asymptomatic period, the quiet period of infection. And you could live for up to 10 years like this, typically, without seeing any signs or evidence that you might be HIV positive. This is why a lot of transmission can occur, because people simply don't know that they have HIV because there's nothing in their body showing them that is the case.